Hi, everyone. Thanks for coming. Welcome back. This week we've been talking about the experimental study design and using mostly the randomized study as the example we've been talking mostly about. And I want to give you the opportunity to hear about a very important study, experimental study, a randomized trial that's being done here at Harvard. And I've asked my friend and colleague, Joanne Manson, professor of medicine at the Harvard Medical School, but more importantly, professor of epidemiology here at the Harvard School of Public Health, and head of the Division of Preventive Medicine at Brigham and Women's Hospital, to talk about this very important study that they're doing, VITAL. So, Joanne, thanks for coming. The floor is yours.
Thank you very much, Fran. It's a pleasure to be here. And I'm very happy to tell you about the Division of Preventive Medicine. It's an honor to serve as chief of that division, which is part of Brigham and Women's Hospital. Our division focuses on randomized clinical trials, primarily in prevention of cardiovascular disease, diabetes, and cancer. Some of the trials we've been involved with include the Physicians' Health Study, the Women's Health Study, Women's Folic Acid Study, and the Vitamin D and Omega-3 trial that I'll be focusing on in this talk. We also do biomarker and genomic research. So in this talk, I'm going to be focusing on the vitamin D and omega-3 trial, a new ongoing randomized clinical trial that's being done in the Division of Preventive Medicine. My talk will focus on the rationale and design of this study, and Dr. Julie Buring will be focusing on the implementation and the operational aspects of this trial. So let's take a look at the overall design of the study. This slide shows that the vitamin D omega-3 trial will include 20,000 initially healthy men and women from across the entire country. The men will be 50 and older, the women 55 and older. These are the ages at which the risk of chronic disease increases substantially. The design will involve the ability to look at the effects of vitamin D and omega-3s independently, as well as whether there's any synergy between the two. This is what we call a factorial design, where participants are first randomized to one of the agents versus placebo, and then further randomized within each of these two groups to another agent. So first vitamin D versus placebo, then the vitamin D, active vitamin D group is further randomized to the omega-3s versus a placebo, and the placebo group further randomized to active omega-3s versus placebo omega-3s. This ends up with 4 treatment groups. One that gets both active agents, 2 groups that get only one of the 2 agents as active and the other placebo, and 1 group that gets both placebos. The mean treatment period is expected to be 5 years, and we will be getting a blood collection in about 80% of the study population. That's our goal, or about 16,000 of the 20,000 will be providing the baseline blood collection and then a follow-up blood in about 6,000, allowing us to look at baseline levels of vitamin D as well as omega-3s, and whether those baseline levels modify the outcomes seen, the effects of the treatment in the trial, and also we will be able to look at the effects of these interventions on biomarkers, a number of biomarkers related to cancer and cardiovascular disease. We'll also be able to do genetic studies with our baseline blood collection. The primary outcomes of the trial, which I'll talk about in more detail, are cancer and cardiovascular disease. So let me show you what the primary and secondary outcomes of the VITAL trial are. It's very important with randomized trials to specify what the aims are in advance and to define the outcomes of the trial. So the primary aims of this trial are to test whether vitamin D supplementation reduces the risk of total cancer and major cardiovascular events. Now, major cardiovascular events is a composite of several major outcomes: myocardial infarction, stroke, and cardiovascular death. We want to do the same, look at the same outcomes in relation to the omega-3s, EPA, DHA. For efficiency, I'm going to focus most of the talk on vitamin D, but virtually all what I say also applies to our efforts to study the omega-3s, EPA plus DHA, or fish oil as well. The secondary aims of the trial are to look at site-specific cancers, whether vitamin D lowers risk of colorectal, breast, prostate cancer, as well as total cancer mortality. We'll also look at an expanded outcome of cardiovascular disease that includes coronary revascularization procedures such as coronary bypass surgery and percutaneous coronary interventions. And we'll also look individually at at these outcomes, such as individually at the heart attacks and the strokes and cardiovascular mortality. So those are the primary and the secondary aims of the trial. The rationale for VITAL is primarily the emerging evidence from several types of studies, animal studies, observational studies, other studies, that vitamin D and the marine omega-3s, EPA, DHA, reduce risk of cancer and cardiovascular disease, but the evidence is not yet conclusive, and the large randomized trials are lacking. As you well know, there's been a lot in the media about vitamin D, and a fairly substantial percentage of the population is already taking supplements, so there's growing use of these supplements in the population. And this really underscores the need to get conclusive evidence on the balance of benefits and risks before this becomes a runaway train, and before it's no longer feasible to do a trial of this nature. There have been no previous large-scale randomized trials of these agents in the primary prevention of cancer and cardiovascular disease. So there's actually a limited window of opportunity for doing a randomized clinical trial. The evidence has to be promising enough to subject many people to an intervention, to an agent, but the evidence can't yet be conclusive. If it's already conclusive, there's no need for the trial. It also has to be feasible. If everyone is already convinced of the benefits, everyone's already taking something, then it's no longer feasible to do the trial. We're right now within this critical window of opportunity for both vitamin D and the omega-3 fatty acids. Now, I want to underscore a key principle of research, because the different types of research that you'll be hearing about and that you've already heard about to some extent are not hierarchical. All of these forms of research are critically important to advancing science and public health. So you have bench research, the basic research, then you have observational studies that are health tracking studies where you're not intervening, but you're looking at associations between lifestyle factors or different risk factors and health outcomes. You have the randomized trials, and then you have translational research where you're applying findings to clinical settings and to populations. All of these studies are tremendously important. And the basic and observational studies will often generate hypotheses to be tested in randomized trials and will be very helpful in informing the science and deciding what is of value in testing further. Now, one of the great benefits of doing randomized clinical trials can be the ability of trials to control for certain biases that can be a concern in some observational studies, especially when you're looking at the role of a nutritional supplement, such as whether taking vitamin D supplements or taking fish oil, omega-3 supplements can lower risk of cancer, cardiovascular disease. There can be potential for confounding by other factors, and the randomized trial design will balance out all these other factors, both the measured factors, the known risk factors for cancer, cardiovascular disease, as well as some of the unmeasured factors. And this is a tremendous benefit, especially if you base it on intention to treat, how the participants are randomized from the start, and you follow them forward. You should be able to limit or really minimize confounding if the study is large enough, if the trial is large enough, as well as factors that relate to adherence and compliance with a treatment. So this is a schematic of what confounding is all about. And a confounding factor, in order for a factor to be a confounder, it needs to be correlated with an exposure of interest. So let's give a really simple example here. Let's say you are interested in the question of whether alcohol consumption increases the risk of lung cancer. So alcohol is the exposure and lung cancer is the disease outcome. If you did a crude analysis of alcohol and lung cancer, you would probably see that alcohol intake was predictive of an increased risk of lung cancer, because it is tremendously important to take into account a key confounding factor, which is cigarette smoking. Cigarette smoking is correlated with alcohol intake. There tends to be a higher prevalence of smoking among people who drink regularly. Not everyone who drinks, but statistically there is a correlation between the two, and cigarette smoking is a very powerful risk factor for lung cancer. So the crude analysis will show alcohol consumption to be a risk factor for lung cancer, and until you adjust or account for the confounding effect of that third factor, you are not going to see the true association between alcohol and lung cancer. Now, you can control for confounding by stratifying. You can look at never smokers, for example. What is the association between alcohol and lung cancer and never smokers? Or you could look at past current, adjusting for amount of past current smoking, and look at the association with lung cancer. But you have to take into account a confounding factor, such as, in this example, cigarette smoking, or you will get a spurious result, a very misleading result. The beauty, again, of the randomized trial is that these confounding factors should be equally balanced between the active intervention group and the placebo group. So they should no longer confound the associations. And even if you don't know what the major confounding factors are, you haven't measured them, just the randomization process in a large enough trial should be able to account for them. Now, in studies of vitamin D blood levels, with a 25 hydroxyvitamin D, which is a marker for vitamin D status, vitamin D exposure, this level can have a number of confounders, which can lead to some associations that we don't yet know are true cause and effect relationships. This is why it is so important for vitamin D to do a randomized trial of vitamin D supplementation and risk of cancer and cardiovascular disease and other outcomes. Here's an example of some of the confounders that we see in just the observational studies looking at associations between a low level of vitamin D and these chronic disease outcomes. First, as you well know, sun exposure is a predictor of the vitamin D blood level because the skin synthesizes vitamin D. So a major potential confounder is physical activity level, because people who are physically active are very often outdoors more often. They're getting exercise, they're running, they're jogging, they're playing racket sports, they're being physically active. Usually there's more activity outdoors compared to a very sedentary person who is, housebound, is not going outdoors, is very inactive. So some of the benefits that are associated with the higher vitamin D level may in fact be due to physical activity differences. And a low physical activity can be a risk factor, an independent risk factor for cancer, cardiovascular disease, type 2 diabetes. Now, another factor is just overall nutritional status. People who are poorly nourished, who have poor diet, they may have a low vitamin D intake, but they also have low intake of many other essential and very important nutrients. And we know that diet is a key factor in terms of our risk of cancer, cardiovascular disease, and type 2 diabetes. So sometimes the low 25-hydroxy-D level or this blood level for vitamin D can be a marker of just overall poor nutritional status. Now, another important potential confounder here is obesity. Vitamin D is a fat-soluble vitamin, and it's sequestered in the fat tissue. And so there is a strong inverse correlation between body mass index and the amount of adiposity and the vitamin D level. It will be lower in people who are obese. And we know that obesity is a major independent risk factor for many forms of cancer, cardiovascular disease, and certainly type 2 diabetes. So when you're looking at observational studies, you can try to control for body mass index, physical activity level, overall nutritional status, but it can be a challenge. It may not be complete control for these variables. Another important factor is in observational studies of people who take supplements, people who tend to be compliant with taking supplements regularly, tend to be more health conscious. There's quite a bit of evidence in the literature that people who are compliant, even with placebo in a randomized trial, this is looking at placebo adherence, taking, if you're randomly assigned to the placebo group and you regularly take the placebo, compared to other people in the randomized trial who are also assigned to take placebo and are poorly compliant with taking their study pills. Let's say the referent is people who are not fully compliant with their study pills, their placebo pills. Those who are taking at least 80% of their placebo pills in the Women's Health Initiative, this is among the placebo, those assigned to placebo in the Women's Health Initiative hormone therapy trials, a very large number of women. There were really striking results just associated with being compliant with study pills. So total mortality was 0.64, a significant 36% reduction. Cancer mortality was also reduced, clinical MI. All of these were reduced by 30–40%, just associated with very good compliance with study pills. And what's most striking about these findings is this is after these hazard ratios are already adjusted for risk factors that we know about and that we often control for in analyses, such as age, ethnicity, education, smoking, body mass index, physical activity. There are other factors that are difficult to measure that can be associated with risk of disease in observational studies, especially when you're looking at something like compliance with taking a vitamin supplement or taking a dietary supplement or a medication, and can be a real challenge to adjust for fully. And this is where a randomized trial of a dietary supplement such as vitamin D or the omega-3s can be very helpful. There are many mechanisms for vitamin D preventing cancer, and I'll show you cardiovascular disease on another slide. These mechanisms are from cell culture studies, animal studies, and small clinical studies. But before we go through these mechanisms briefly, I do want to highlight that there were also strong mechanistic pathways for beta carotene and vitamin E and folic acid to prevent various health outcomes. And when the large randomized trials were done, they were not shown to be of a clear benefit in preventing chronic disease, cancer, cardiovascular disease, and in some cases risks were also identified. So it really highlights that it's still important to do the randomized trials and to get data from actual human populations with large enough sample sizes and long enough follow-up. There are several mechanisms through which vitamin D may lower risk of cancer. There's some evidence that vitamin D inhibits cell proliferation, causes cell differentiation, inhibits the growth of blood vessels, new blood vessels that can feed tumors and can enhance the risk of metastasis, and also clear evidence that vitamin D inhibits inflammation. All of these pathways may be involved in cancer or the prevention of cancer, but we really need the large-scale randomized trials in human populations to know if vitamin D supplementation will prevent cancer in the population. We know from several observational studies that a higher blood level of vitamin D is linked to a reduced risk of many cancers, in particular colorectal cancer. For example, a meta-analysis of 5 observational studies of blood levels of vitamin D and risk of colorectal cancer showed in aggregate that the highest versus the lowest quintile was associated with more than a 50% reduction, 0.49 odds ratio, and that was highly statistically significant. But again, what are the potential confounders in this analysis? Some of these studies did not have perfect control for physical activity levels, for body mass index, for other nutritional factors, and all of these variables can be strong predictors of colorectal cancer risk. So again, even though the evidence is quite promising from observational studies that higher blood levels of vitamin D do seem to be linked to reduced risk, colorectal cancer, where the associations tend to be quite strong, there's still potential for some confounding in these studies. This slide shows that the randomized trials to date have not clearly shown benefits. So if you look at randomized trials of vitamin D supplementation and total cancer incidence, there hasn't yet been a trial before VITAL that was designed to look at cancer, but many of these trials were designed to look at vitamin D and fractures and bone health, and we're also able to look at cancer. The bottom line here, I'm not going to take you through all the details because it's not necessary, is that not a single trial has yet clearly shown cancer prevention, but these trials tested generally lower doses of vitamin D than we're testing in VITAL. We're testing 2,000 IUs a day in VITAL, which, as I'll show you, should get the vast majority of the VITAL study participants to a blood level that has been linked to a reduced risk of cancer in many of the observational studies, whereas some of the previous randomized trials were testing lower doses, such as only 400 IUs a day or up to 1,000 or 1,100 IUs a day, and we are testing 2,000 IUs a day. So the fact that these trials were not positive don't cast doubt on the possibility that the results will be favorable with higher doses, but certainly do not yet have any clear evidence from randomized trials that vitamin D will prevent cancer. Here are mechanisms for vitamin D to prevent cardiovascular disease. Some of the pathways are similar. Inhibition of inflammation, which is important in the pathway for cardiovascular disease. There are effects of vitamin D in inhibiting the smooth muscle proliferation in the arteries, decreasing vascular calcification unless the dose is too high. Regulating blood pressure and volume may have a role in preventing heart failure as well, and regulating glucose metabolism and insulin resistance. Again, this is a little maybe difficult to see, but just showing the randomized trials to date have been null. They have not yet shown, very few randomized trials, but they've not yet shown that there is a reduction in cardiovascular events with vitamin D supplementation in these limited number of trials. Again, the dose has been low, only 400 to 800 IUs a day in these 2 trials. So again, it's not casting doubt on the possibility that the higher dose, 2,000 IUs a day, will prevent cardiovascular events. The justification for the dose that we've chosen, I've mentioned the 2,000 IUs a day. It really seems to be an excellent balance of efficacy based on the blood levels it will achieve, it would be expected to achieve, and what's been seen in the observational studies, and also should not be such a high intake and lead to such a high blood level of vitamin D that there would be concerns about toxicity or risks. So it seems to have a good balance, and it should get the majority of our study participants to at least to about 90 nanomoles, or a range between 75 and 100 nanomoles, and that is a range of blood levels that has been associated with reduction of many chronic diseases in observational studies. And it should also lead to about a 35 to 50 nanomole increase in the blood level compared to baseline, which is about doubling the blood level compared to the placebo group. As Dr. Buring will discuss in more detail, we are striving for a very diverse study population in terms of race and ethnicity. We hope to have at least 25% African Americans, and we're projecting now that we'll have only 65% of the non-Hispanic white, and that's quite unusual for a randomized trial. Usually the diversity of the population in randomized trials is not as great as this. We're really hoping to be able to test whether vitamin D supplementation can reduce some of the health disparities related to race and ethnicity, in particular some of the increased risks that have been seen of various chronic disease outcomes among African Americans, including stroke and hypertension and certain forms of cancer and cancer mortality. And so a key question is whether supplementation with vitamin D can reduce some of those risks. Now, we have several ancillary studies that have been funded, will enable us to look in great detail at other outcomes. Cognitive function, we're going to be looking at effects over time in terms of cognitive testing, diabetes and glucose tolerance, hypertension, asthma, and respiratory diseases, autoimmune diseases, diabetes, kidney disease, fractures, bone health, mood disorders, depression, infections, imaging studies of the cardiovascular system, eye diseases such as macular degeneration, and even anemia. We have some studies that are still pending, including genomic and telomere studies, as well as looking at some other cardiovascular outcomes such as heart failure and atrial fibrillation. Now, I want to mention that another advantage of this large-scale clinical trial design is that it allows you to do a hybrid of a very large study population where you can cost efficiently mail study packs, calendar packs to people around the country, get medical records, get consent for medical record review, and look at a large number of clinical outcomes. But you can also have an in-clinic visit and in-depth phenotyping of a subset of the population, where we really look in detail at several other factors. So in the Boston area, we are having clinic visits. We're aiming for 1,000 vital participants to come in and have their blood pressure measured, have height and weight and anthropometric measurements, a urine collection, a 2-hour oral glucose tolerance test, lung function through spirometry, detailed physical performance and strength and balance and performance testing, an additional cognitive function test, the 2D echocardiogram, and also bone imaging to look in detail at both DEXA and also body fat and body composition by DEXA, and bone microarchitecture. So it's an opportunity with this hybrid design to have a very cost-efficient trial with a large number of clinical endpoints, including participants from around the country, but also to do some very detailed testing of a smaller sample in the clinic and do imaging testing and 2-hour glucose tolerance tests. Really think that VITAL will provide just a treasure trove of information about the relationship between vitamin D as well as the omega-3s and many, many chronic disease outcomes. So in conclusion, vitamin D here and also omega-3s. Vitamin D it's a promising intervention for the prevention of cancer, cardiovascular disease, many other chronic diseases, but the conclusive evidence for its efficacy in primary prevention is lacking. And this is why a randomized trial, a primary prevention randomized trial is very important. There actually is not evidence from secondary prevention trials either for vitamin D, but a primary prevention trial will really enable a very powerful test of the hypothesis. VITAL is the first large-scale randomized clinical trial of vitamin D in the primary prevention of cancer and cardiovascular disease. If you want to learn more about the study, the website is vitalstudy.org, and we're hoping to be completing recruitment over the next several months, and we're really looking forward to the 5 years of treatment and follow-up and learning as much as possible about the role of vitamin D and omega-3s in preventing chronic disease and improving population health. So thank you very much for your attention. This is Joanne Manson.